So my presentation is radiotherapy of non-small cell lung cancer. But before I get into my case study, I would like to give an overview of the lungs and the different types of cancers that occur in the lungs. General overview of lung physiology. As we all know, normal respiration begins by inhaling air through the mouth and nose. This air flows down your trachea, which divides into the left and right bronchi, which carry air to each lung. Once inside the lung, the bronchi divide into smaller tubes called bronchioles, and each bronchiole ends with alveoli. The alveoli are responsible for oxygenating the blood for circulation, as well as removing carbon dioxide from the blood. As you can see in the diagram here, the right lobe has 3 sections or lobes, and the left lung has 2 lobes. The types of lung cancer. There are 2 main types of lung cancer. 95% of lung cancers are classified as either small cell lung cancer or non-small cell lung cancer. Small cell lung cancer is the most aggressive form of lung cancer. It usually starts in the bronchi, which is problematic because post-pneumonia and atelectasis often occur. These cancer cells are small and are considered to be quite aggressive in nature, and they have a large growth factor. Because of these reasons, at the time of diagnosis, 60% of the time, these tumors have often metastasized to other parts of the body, for example, the brain, liver, and bone marrow. Small cell lung cancer accounts for 20 to 25% of all lung cancers. Non-small cell lung cancer is any type of epithelial lung cancer other than small cell lung cancer. Non-small cell lung cancer usually grows and spreads more slowly than small cell lung cancer. There are 3 subtypes of non-small cell lung cancer that include squamous cell carcinomas that usually arise centrally in larger bronchi, adenocarcinoma, which are often found in the periphery of the lungs, and large cell carcinomas that can occur in any part of the lung and tend to grow and spread faster than the other 2 types. Squamous cell is most likely lung cancer to present as a Pancoast tumor, which is located in the lung apex with extension to the chest wall, which can cause shoulder pain that radiates down the ulnar nerve. Squamous cell carcinomas are also known as epidermoid cancers, which make up 30 to 40% of all lung cancers. This type of cancer is characterized by having cells that are moderate to poor differentiation. This cancer is more common in males. Most originate in the portion of the lungs such as the large bronchi. It is hard to detect on X-ray. For this reason, diagnoses are often delayed. Uncommon metastasis that is slow affects the liver, adrenal glands, and lymph nodes. Adenocarcinoma is the most common type of lung cancer. It makes up 40 to 50% of all lung cancers. Most of these cancers originate in the peripheral areas of the lung, like the bronchial mucosa, and can also begin in scars caused by fibrosis, which are easily seen on X-rays. It can occur in non-smokers. It's more common in women, which is strongly linked to smoking. It's highly metastatic in nature, and generally patients present or develop brain, liver, adrenal, or bone metastasis with this type of cancer. Large cell carcinomas make up 15 to 20% of all lung cancers. It's poorly differentiated in appearance, tends to occur in the outer part of the lung, invading the subsegmental bronchi or larger airways. Metastasis is generally slow, but early metastasis occurs to the kidney, liver organs, as well as the adrenal glands. So this is just a recap of the images that were shown previously. You can see the small cell lung cancer, squamous cell, and adenocarcinoma. With the small cell lung cancer, it's located in the bronchi, and the squamous cell cancer, the top image has it in the high apex of the lung, which is known as the Pancoast tumor. And then the adenocarcinoma, over there on the patient's right side, you can see the tumor volume, which is in the periphery of the lungs. So now that we've just talked about the different types of lung cancers, I'm going to start with my case study, which involves a 76-year-old male that went to the doctor with a chief complaint of chronic cough and dyspnea. A chest x-ray was performed and revealed a right upper lobe infiltrate, and the patient was prescribed antibiotics with a follow-up CT. And in the image over here, I have a red arrow pointing to this more dense object that's located in the right lung. The CT scan showed a spiculated mass in the right upper lobe measuring approximately 4.38 centimeters in the largest axial view, which was later identified to be squamous cell carcinoma stage 2A T2B N0M0. A smaller solid lesion at the inferior aspect of the left lower lobe measuring approximately 2.72 centimeters by 2.57 centimeters in the axial and coronal plane, which was then later identified as a non-small cell lung carcinoma stage 1B T2A N0 M0. With the diagnosis in place, the patient care plan was to resect the right upper lobe mass and follow up with radiotherapy for the smaller lesion located in the lower left lung. So in the image, the top image, you can see the right upper lobe mass, and then the lower image, I have it labeled the left lower mass. When the patient returned to radiotherapy, he was simulated using a CT scanner, and both expiration and inspiration CTs were required to better define the target volume. A PET CT was also performed, but not used in the planning process because the physician did not see positive extension in the lower left mass and decided it did not provide any other vital information for the planning process. SBRT with the fractionation of 4 × 12 gray was the original intent for this treatment delivery, but because of tumor movement and the uncertainty of this movement around the organs at risk, the physician decided against SBRT because of the high dose and substituted it for what he likes to call SBRT light. SBRT light is simply hypofractionated radiotherapy and was introduced as an alternative treatment option for facilities that wanted better tumor control but didn't have the necessary equipment to execute SBRT. Patients eligible for this treatment are those diagnosed with stage 1A or 1B non-small cell lung cancer with a solitary parenchymal lung lesion measuring less than or equal to 4 centimeters. It is a prescribed dose of 70 gray given over 15 fractions or 4.11 gray per day. Because of the tumor movement and the organs at risk adjacent to the tumor, this was a better, more suitable treatment option because it would provide better control than standard fractionation. So rapid arc was the selected mode of treatment delivery. 2 partial arcs were used, one being a counterclockwise arc starting at 179 degrees and ending at 330 degrees, and a clockwise arc starting at 330 degrees and ending at 179 degrees. A collimator rotation of 330 degrees was used on the counterclockwise arc, and a 30-degree collimator rotation was used on the clockwise arc to increase the latitude of treatment coverage calculation. The ITV was defined by the physician using the inspiration and expiration CT datasets with a 1 centimeter expansion in all directions, creating the PTV. So in the image here, I just have a picture of the ITV, which is the salmon pink color, and the PTV, which is yellow, and then a 3D renderation of that volume itself. Some of the concerns during treatment planning were the doses to the spinal cord, stomach, heart, and lungs. Appropriate objectives were placed with appropriate priorities to each critical structure, ensuring dose did not exceed the maximum tolerance for these structures. And in the picture here, I just have several structures that are just lined out and defined by the arrows pointing at them. So you can see the stomach with the magenta color, and then the cord, which is the yellow, both lungs right and left, and the heart, which is that darker red-brown color. So this is the DVH for dose reporting, and it's according to the Quantex that was given to us. The goal for the spinal cord was a volume receiving 32.1 gray equals 0%. Total lung volume receiving 14.3 gray is less than 30%. The heart volume receiving 21.4 gray is less than 50%, and the stomach receiving 32.6 gray is less than 50%. So if you go right across where the actual dose report was, the volume receiving 32.1 gray was 0%, with a mean of 4 gray and a maximum of 25 gray for the spinal cord. The volume receiving 14.3 was less than 12%, with a mean of 6.8 gray and a max of 76.05, and that's due to the fact of the partial arc exposing the one side of the lung. The volume receiving 21.4 for the heart was less than 3.4%, with a mean of 9.5 gray and a max of 30.3 gray. And the volume receiving 32.6 for the stomach was actually less than 1%, with a mean of 7.8 and a max of 47.2 gray. So all of the objectives there were actually met, given the criteria from Quantex. Then looking down on the ITV, you can see that the volume receiving 70 gray, we wanted to have 100% in theory. So the volume underneath that, the 68.6, which is 98%, we would like 100%. And then the volume receiving 66.5, which is 95% of the total prescription dose, we wanted to have 100%. So then going over to the right, you can see that the volume receiving 70 gray for the ITV was actually 91%. The volume receiving 68.5, which is 98% of the prescription, was actually 100%, so that was good. And then the volume receiving 66.5, which is 95% of the prescribed dose, which was 100%, which of course, because of the 98, we knew that was going to happen. Going one step further, the PTV, we had some objectives on that, or goals, and the volume receiving 70 gray, we wanted it to be 100%. The volume receiving 68.6 or 98% of the prescription dose, we wanted to be 100%, and the volume receiving 66.5, which is 95%, we wanted it to be actually 100% of the volume. But going over to the right, you can see that the volume receiving 70 gray on the PTV was actually 83%, a little low, and the volume receiving 68.6%, which is 98% of the prescription dose, was actually 97%, so that was good. And then the volume receiving 66.5 or 95% of the total prescription dose was 100%. So with that, our goals were met. The PTV was covered with 95% of the total dose, and so the physician liked the plan and wanted to carry on through with treatment. And this is just a DVH of the actual plan itself, the spinal cord being the yellow there, and you can see the doses are relatively low. The total lung is the blue line. Heart is that darker red color. The stomach is the magenta. And then the ITV 70 is that pink kind of salmon. It's kind of difficult to see, but it's over there in the top right hand corner. And then the PTV 70 is the yellow color. So here's just some cross-sectional views of the overall tumor coverage. I have defined the 70 gray line, which is the red, the 68.6, which is the 98% line, which is green, and the 66.5 gray isodose line, which is blue. And as you can see, the dose starts to build up slightly, and then we start seeing the tumor volume itself incorporated in the lower slices. But as we scroll through, we will see that the 95% line, or the 66.5 gray line, is actually covering the tumor quite nicely, along with the 68.6, which is the 98% line, the green one. The 70 gray itself is kind of busted up, and you can see it kind of spiculated within the tumor volume itself. But as we continue on through, we can start to see that, the tumor volume itself is covered quite nicely with the 95 and 98% line. But the overall goal being that at least 95% of the prescribed dose is covering the entire 100% of the tumor volume, which we achieved with, given the fact that we looked at the DVH, and that's what it was. And so just scrolling through the patient, we can see that now it's just ending and trickulating off, and that is the end of the tumor coverage. So before the plan was actually delivered, a secondary MU check was done by importing the treatment plan into the PTW Diamond, which is what we currently use at the clinic. And before the treatment was delivered, a QA plan was done using map check by our physicist, which it came to be within 2% of the expected values from the treatment planning system. So some of the side effects this patient may experience are fatigue, decreased nutritional intake, radiodermatitis, decreased hematopoietic function, risk for pneumonitis, esophagitis, and cough, dysphagia, adonophagia, temporary or permanent deterioration in pulmonary function, and this could be attributable to interstitial lung fibrosis. As for therapist instructions, not a lot of special instructions were given to the therapist. This treatment included an SBRT setup with designated parameters that were defined at the time of CT. As for imaging and patient alignment, the physician ordered a cone beam CT, which was done on a daily basis. With every day in dosimetry comes an opportunity to learn something new. I was originally going to plan an SBRT treatment, but learned about a new type of fractionation that I had never used before. It was also a great experience because I was able to ask the doctor why the patient, in his eyes, was not best suited for SBRT. I did think the plan was pretty straightforward and somewhat easy, but at the same time I feel like I could have done more. For example, I would have liked to have run a static IMRT plan and full rotational arcs to see what the difference was, but because the physician wanted the patient to start immediately, I didn't really have that opportunity. I think that as I advance into the actual work field of dosimetry, my foundation for what I am capable of doing will only increase.